Hi, my name is Dr. Michael Wilkes. I'm a professor at the University of California at Davis and spend a good portion of my time working in global health in East Africa, in Asia, Central and South America, and spend a rest of the portion of my time involved in medical education, teaching medical students and residents and looking at how to change doctors who are practicing in the community. Early detection for disease is important, and we've come a long way. Unfortunately, we've sort of opened the floodgates, and we've promoted everything as being equal to everything else. And there's a field of medicine and research called technology assessment, which is looking at a technology, a laboratory test, a drug, a procedure and surgery, and evaluating its benefits, its harms, its risks before it gets out into common use. Unfortunately, it's really hard to get funding, and there's a huge incentive for the manufacturers of those products not to want to see that data, not to want to compare something that's new with something that's existing, not to want to look at a surrogate marker. This concept of surrogate markers, before I talk about screening, is really important to understand in that we have a continuum, and there are bad things that happen to people. Let's take the example of heart attacks and strokes. What doctors and nurses and PAs and nurse practitioners all strive for is to reduce the risks of strokes and heart attacks. And that's what we would call a patient-oriented outcome. That's what my patients want. That's what I want. It's hard because it takes a long time to study those things. You have to live, you have to study until the patient no longer lives to see if some intervention really does reduce the risk of heart attacks, really does increase either the quality or the quantity of somebody's life. So we've looked long and hard for these markers that might be a step along that pathway. And depending on the disease, we've got a number of these markers, and we call them surrogate markers. In the best of all circumstances, these surrogate markers are predictors and accurate predictors of the disease that we're looking at. But sometimes those markers become an entity of them in and of themselves. So if you look at high blood pressure, nobody really ever died of high blood pressure. What they die of are strokes and aneurysms and heart attacks. So we have a lot of drugs to reduce blood pressure. We call them antihypertensives. But we know that some of those drugs are very effective at producing a drop in heart attacks and strokes and aneurysms. But we know that other drugs that reduce blood pressure an equal amount aren't effective at that. So if we are blind and just look at the surrogate markers, we would assume that all of those drugs are created equal when they're not. And sometimes we put all of our credibility in these surrogate markers and forget that, wait a second, we're really not here to treat blood pressure. We're here to reduce disease. Blood pressure, high blood pressure, is not a disease. It's a marker of disease. And we have to be careful that we don't get into a whole a whole cycle of treating surrogate markers and not disease. The same is true with cholesterol. You had asked me to give some comments about prostate disease and mammograms. Both of them are screening tests for what are serious diseases. So I think some of us have questioned the utility of those screening tests, but it's important that listeners understand that it is not an attempt to ditch those diseases. They are important diseases, and all of us would love nothing more than to reduce the risk of breast cancer as close to zero as we can get, and the same thing with prostate cancer and a number of other things. On the other hand, if you take a screening test that's looking for disease before there are any symptoms, you've got to prove some things. You've got to prove that that marker really is a marker of that disease, and you have to prove that if you do something, it's going to make a difference. So we don't screen for things that we know we don't have any intervention for. So one of the problems with prostate cancer is that there are a number of different treatments, watchful waiting, surgery, radiation, and at this point there's very little data that one of them is any better than the other. The other is the accuracy of the test. And if viewers think of a bullseye, there are two ways I could throw a dart at that bullseye. I could throw a dart and try to hit the bullseye and be all over the place. That would be a measure of what we call accuracy. On the other hand, there's a concept of reliability or reproducibility. So let's say I throw a dart at the bullseye and I miss. And then I throw a second dart and a third dart and a fourth dart. But they're all hitting, at about 2 o'clock away from the bullseye. Well, it isn't accurate because they're missing the bullseye, but it's very reliable. I'm hitting that same mark, even though it's not related to truth, time and time again. Well, with a screening test, it's really important that the screening test be both accurate and reliable. We want to hit the bullseye. We want to keep hitting it again and again and again. The problem with PSA testing is that it doesn't give us an accurate predictor of onward cancer. There are two things that can happen. The more common is that it tells us that someone has cancer when they really don't. Secondly, there are admittedly two kinds of cancer, if you will, of the prostate. One kind of cancer is serious. It causes death. The other kind of cancer we don't really understand, but we know men die with that type of cancer, not of that kind of cancer. So ideally, you'd want a screening test that wouldn't pick up the background noise cancer, but you'd have a screening test that would pick up the disease-causing kind of cancer. PSA test doesn't do that. So is it a bad test? Well, it's not a bad test if it's used under certain circumstances, meaning if you're African American, if you have a family history of prostate cancer, if you're the kind of person that really wants to do everything possible and are willing to put up with the consequences of that, it's a test that has some important uses. If, on the other hand, you're like most men, where you don't want to be impotent from surgery, you don't want to be incontinent, and you want, before you do anything aggressive about your health, to know that there's a good chance that it's going to benefit you, prostate cancer testing with a PSA is probably not the way to go. Mammograms. Mammograms are low exposure radiation applied to the breasts. For the men that are listening to this, it's not a particularly fun test. They take the woman's breast and literally sort of squish it or mash it between two plexiglass plates. It's uncomfortable, and some of it depends on the size of your breast, and some women are more sensitive with breast tissue than others. But, the actual mammogram doesn't cause any problem, neither does the PSA test, which is a blood test. It's the downward consequences of that. So the problem is that when we do a mammogram, the radiation itself can induce cancers, not probably one mammogram, but repeatedly unnecessary mammograms have the potential of causing some real harm. And the abnormality that's picked up is more often than not a life-threatening disease. So these women who have a small calcification end up getting a biopsy. A biopsy involves sticking a needle into the lesion, usually the way some of us did play with Play-Doh when we were little with a straw. And remember, you took the straw and then you took a piece of wood or a stick or something and put it through the straw, and out came this round tube. Well, that's exactly what we call a core biopsy is. And then that tissue, not Play-Doh, the tissue gets sent to a pathologist. And the pathologists are good, smart men and women, but they're not able, they don't have a crystal ball, they're not able to say which of these is really serious cancer and which isn't. There's a common classification called Dcis, which has just been in the press a lot because it turns out that it is not associated with cancer, but it has affected as many as 60,000 women each year who go on and get either a lumpectomy or mastectomy, as it turns out, for not very good reasons, and certainly not that it's going to save their life. So where am I going with all of this? The idea is that, screening tests have the potential of being really important. There are a number of screening tests that we use for colon cancer, and I won't go into the details, but 3 common ones include the colonoscopy, a sigmoidoscopy, and what we call a guaiac, a test looking for a blood that isn't visible, sort of invisible blood in stool. We've shown that those tests, they're not all equal, and there are different benefits of each of them, but every one of them has a benefit and has really reduced the incidence of colon cancer and deaths from colon cancer. It's a, I don't know if it's a home run, but it's a second or third base hit. I mean, it's been a major advance. And, if they're not perfect, and we could do some better around colon cancer screening, but the tests themselves are pretty good tests. Then we've got some tests that really are of dubious value. And I'm not prepared to say that they're of no value, but what we want to get to is a point where a doctor and a patient sit down and have a meaningful conversation in understandable English that isn't a doctor lecturing to a patient, but really talking about their values. What is important to you, Mr. Jones, about your life? How important is it that you do every single thing possible? How much would you be worried about not being able to be sexually active with whoever it is you want to be sexually active with? How upset would you be about dribbling into a diaper, for years and years after a treatment for a surgery that might not have killed you, but it might. We don't know. What of those things are really important to you? And then coming up with a decision. And, if I could make one last point, it is that one of the things I always get asked is what would you do, doctor, if you were me? And I think it's really important to stress that your doctor is your doctor, and his job or her job is to be your advocate and to find out this information about you and to have a conversation with you to present clearly the best scientific thinking on the topic. But your doctor, you haven't chosen your doctor because his or her values are the same as yours. Chances are you know nothing about your doctor and their religion, their values, what they think is important, what role cancer has played in their family, and all of those things make us people and make us unique. So it's not really fair to ask your doctor what they would do if they were you, because they're not you, and they can't possibly be you. The only thing they can do is try to tease out from you what are the things that you think are important and help you make that very best decision for you.